Steve Calvin, welcome to the show.
Thank you for having me.
We're delighted to have you on the show. We're going to talk about your specialty, maternal fetal medicine, in relationship to COVID. We're going to talk about the problem with maternal mortality in general. We're going to talk. I mean, there's a lot to talk about in your field. I don't think we've ever had a person with your background on the show, so I'm very happy that we're going to have a chance to discuss all these things. But first of all, why don't you walk us through your professional path? I was looking up. I mean, you've had you have an impressive list of accomplishments, but take us back to maybe medical school or.
Sure.
We don't have to spend a lot of time, but I think it's always interesting to see.
I appreciate that, and I went to medical school at Washington University in St. Louis. I was very happy to go to school there. I went to college in Minnesota, and during my medical school training, I had the feeling that I really wanted to be a family medicine doctor, which, as you can imagine, at WashU, it's not encouraged, not back in the late 70s for sure. So I was one of a few students out of our 135 that said they wanted to do family medicine, but very quickly I realized that pediatrics was part of family medicine, and crying children drive me crazy. So I could not be a family medicine doctor. And I also found that I really enjoyed obstetrics. So I went ahead and did a obstetrics and gynecology residency at the University of Minnesota. Mm-hmm. And I had a National Health Service Corps payback that I had to do. And I did that in Tucson, Arizona. So I was a National Health Service Corps OBGYN doctor down in Tucson, where I'd actually grown up, although I was born in Minnesota. All of us returned to Minnesota, it seems like. But that experience in Tucson was really a good one. I was taking care of mothers that are Spanish speaking, or mothers that were from the Papago Indian reservation, mm-hmm. called Tohono O'odham. So it was really interesting. And I also then was a junior faculty member at the University of Arizona. And then I did a fellowship in maternal fetal medicine. And then a little over 30 years ago, I returned to Minnesota. It was a better place for our kids to grow up. And we ended up being here for 30 years. For the 20 of those years, I was a maternal fetal medicine specialist with the group from 5 to 16 of us. So I sort of say I know everything possible that can go wrong with mothers and babies, mm-hmm. because I've had that 20 plus year experience. And I was a faculty member as a clinical adjunct at the University of Minnesota, and ran their maternal fetal medicine service as a co-director, involved in residency teaching, and some research stuff as well. But then at a point in my career, and you guys I don't think are quite there, early mid 50s, I determined that if I was going to be on call every night, I was starting to think that Mrs. Carlson was bleeding in the middle of the night just to make me mad. And when you get to that point in your career, you have to do something different. Mm-hmm. So I then started working with midwives as my 2 daughters and daughter-in-law started to have children. And throughout my medical career, I saw that pregnancy is not a disease state. And certainly I saw a lot of bad things that can happen, but I'm very convinced that pregnancy, particularly probably 3/4 of pregnancies, could really be better cared for by a team of midwives integrated with physicians. And so I ended up starting a birth center with midwife colleagues. And now 10 years later, we've had 3,300 births. We do about 400 births a year. Most are intended to be at the birth center right next to the hospital. It's independent, but integrated. So that all then led, I think that led to this involvement on the HHS Secretary's Advisory Committee on Infant Mortality. It used to be called SACM. Now it's the Advisory Committee on Infant and Maternal Mortality. And I've been 2 years on that and have 2 more years to go. And it's been a real eye-opener. I'm really impressed by some of the work, a lot of the work done by the CDC and other people. It's housed in HRSA, Healthcare Resource Service Administration. So anyway, I've been on that committee and learned a lot. I just, I think that so much of what's going on, there are important things about maternity care that need to be talked about. And sometimes the narrative gets hijacked. So I would describe it as, and I think listening to you guys, listening to Vinay Prasad, listening to Jay Bhattacharya, everybody's saying, well, we're doing evidence-based decision-making. And I'd say, no, mostly it's decision-based evidence-making. And that sort of drives me crazy. So anyway.
Right. Well, that's great. A lot to talk about. I mean, I think this is fascinating. Before, just a couple of things before we keep going about your background. Before you took on that, you were called to serve on that committee at the HHS. Did you have much? You said you were, a faculty member at the University of Minnesota, but were you primarily a clinical faculty, or did you have any kind of involvement with epidemiology and public policy or things of that sort?
Well, I really hadn't anything formal. I have a colleague. We're actually doing some work on the safety of out-of-hospital birth and all of that. So I've become educated over time, but I don't have any formal background in that. Okay.
Well, fine. And then just for the audience, can you explain what maternal fetal medicine is? If those who are not MDs or in healthcare in the audience, because it sounds like any OB doctor is a maternal fetal medicine doctor.
Yeah,
so what's the distinction
right.
there?
And that is certainly true. So the pathway to maternal fetal medicine is through general obstetrics and gynecology, a 4-year residency. And when I did it, it was a 2-year fellowship, but fellowships in maternal fetal medicine just basically specialized in the care of high-risk mothers, babies. There's some fetal treatments. When I started, there were some intrauterine transfusion kinds of things. I did a little bit of that. A lot of the interventions like laser treatment for twin transfusion. I just over time basically was just taking care of every kind of thing that came our way, and then teaching residents and students and trying to make sure that good care was provided. But I wasn't paying as much attention, especially to how care was paid for. I didn't watch your last episode, which was yesterday. I guess the ownership of patients by way of, the
non-compete clauses, right?
Non-compete clauses. So I've had an education over the last 10 years, and I just feel really fortunate to be involved in, trying to be an advisor with a group of people, some who don't agree with me on very much at all, but we try to, maintain collegial relationships, and I've learned a lot.
Sure. But so to be clear, a maternal fetal medicine doctor is primarily a hospital-based specialist who gets called in when there's a problem with the baby primarily, or with the mother, or both, or?
Yeah, mother and baby, the dyad. Okay. And actually, too, I'll point out as well, there's an awful lot going on with kind of the renaming of pregnant women. I mean, it's almost jarring to keep hearing pregnant people, pregnant individuals. Some of the, we can maybe discuss the Wall Street Journal article from yesterday talking about the fact that women, moms vaccinated for COVID are now actually having a higher rate of breakthrough in, infections. And there's a lot of explanations. The whole WAPO article is all, I didn't find mother or woman in that entire article, although I saw it reprinted in our Minneapolis paper, and they did substitute women. I think, that's a whole separate topic, but it's jarring, and my daughters refer to it as gender washing, and they're really
right. I understand. So Steve, we're going to talk about COVID and any misperceptions about COVID risks and pregnancy and that sort of thing. But that comes within a background of a concern that had been raised before COVID about maternal health or rising maternal mortality rates in the U.S. So tell us a little bit what's first of all, just the rough epidemiology. I mean, is it the case that maternal mortality has increased in the U.S. Over the last few years, and is that different from trends in other similar countries? And what's the story there?
A lot is being made of increases, and they are real increases. Back around 2010 or 2012, there was a change in the way maternal mortality was was basically reported. So
Mhm.
there was an increase based on that, which is acknowledged by the public health world. There are certainly disparities related to race. And we can talk maybe a little bit further about that too. Some of them are also very real. I mean, I'm aware, having sat on this committee as well, that to hear some of the stories of Black or Indigenous women, some of the ways they're treated within the healthcare systems, it's very real. I think, though, it's a big mistake to attribute everything to some sort of a nebulous systemic racism.
Mhm.
And we have to be careful about overdoing that. But so maternal mortality, I mean, just to the big picture, I think, is about 100 years ago, somewhere between 500 and 700 women per 100,000 births died in pregnancy. And so if you look through cemeteries in the US and around the world, you'll see gravestones that have, a young woman and the baby sometimes buried next to her. It was not unusual. It was like probably 1 in 150 pregnancies, a woman would die.
Mm-hmm.
And there are a variety of reasons for that. The lack of ability to do cesarean section, blood transfusion, had not occurred, antibiotics, all of those kinds of things. So from about somewhere between 500 and 700 per 100,000 live births, we can further discuss down the road, should we be using the denominator as live births or all pregnancies? But in any case, it's fallen now to a range where we thought it was in the range of maybe 8 to 15 per 100,000. Now it's probably closer into the mid 20s per 100,000. And for Black women, it is in the 40s. So there is a significant increase. It's a pretty rare event, So in the case of Minnesota, we have about 70,000 births per year, live births. And we probably end up having maybe 10, 15 mothers or fewer dying. And every one is a tragedy. And there's a whole range of causes for that: blood loss, infection, cardiovascular disease after pregnancy, ending up with heart failure and whatnot after pregnancy. And it sort of divided up to antepartum and then intrapartum and then postpartum up to 42 days or sometimes a year. It's really complicated how the statistics are described, but there has been tremendous improvement. And I don't think we should ignore disparities. There's no question about that.
But to be clear, when you say that there has been improvement, that means in the last 10 years to address the rise, or improvement since 100 years ago? Or
yeah, actually, the majority of the improvements happened in the 50s up to about the 1950s.
Okay.
So there was, just to get some clarity, there was a change in how we identify a pregnancy-related death, correct? So can you just talk to us a little bit about that? And I know this change happened, some years ago, like a decade ago or something like that. And I bring it up because part of the rise in, there's this. If you look, and by the way, let me just emphasize that, maternal mortality now in this current era is incredibly small compared to what it was in a prior era. When you look at maternal mortality plotted over the last 100 years, right? It's a crazy graph, right? It's like way up here and then it dives down here. And so it's important, I think, that people realize that when you're looking at these changes in maternal mortality rates that have been talked about in the last 10, 15 years, that it looks like this meteoric rise up, but you have to look at the scale on the other side. I mean, the scale compared to what it was historically is of course, much different. So, but some of but anyway, I'll let you speak to this, how we go about measuring this and this checkbox that was added on these death certificates.
Right. Yep. And that's a good point too. It was that checkbox saying that pregnancy had occurred, during the year before a death occurred. I think there's a really good article from the Online Journal of Public Health Informatics that came out in 2019, and it's some folks related to the Charlotte Lozier Institute. I don't know if you're familiar with them, in Arlington, Virginia. They're affiliated with the Susan B. Anthony list. mean, it's a pro-life organization. I'm familiar with a lot of the people that work there and do research, and I've written a paper so for them as well, just kind of a position paper. However, they really, I think, make a very good point. I mean, the title of their article is Improving the Metrics and Data Reporting for Maternal Mortality, and it's a challenge to public health surveillance and effective prevention. They're just pointing out that the current maternal mortality ratio is really not helpful because it's just using a ratio to 100,000 live births. And in the US in any given year, I mean, we do have about 3.7 million. It used to be around 4 million births per year. But we actually have somewhere around 6.9 million pregnancies. And some pregnancies end in spontaneous losses. Some pregnancies end in elective terminations. The elective termination numbers have dropped pretty significantly over the last number of years as well, but they're still in the range of the high 800,000s probably. So anyway, these folks are just saying, look, if you really look at it and you correct for the fact that if, you know, the population of mothers, I mean, so the numerator and then the denominator is hard to come at sometimes because there are 50 states. There's been a lot of great work. So there are people at the CDC. I've really got a lot of respect for people like Wanda Barfield, who's the director of reproductive health. She's a neonatologist. So they do a lot of really good work, but they're trying to put together data that's coming from 50 states. Sometimes it's just all over the place about, you know, what is actually being reported. There's a lot of improvement recently. So I think the data is cleaning up. But so the numerator sometimes is hard to get at, and the denominator, you know, we should be looking at pregnancies no matter what the eventual outcome. So, you know, what kind of losses occur with spontaneous losses, pregnancy losses. So they make a really good, in fact, I'll end up maybe forwarding this.
Yeah, we can put it on the show notes for sure.
Yeah.
So, but to the point is that until recently, relatively, so most states relied on a death certificate that was created in 1989. And then in 2003, there's now a dedicated question on the death certificate, which specifically says, you know, was this person pregnant at the time of, was the person pregnant within the past year,
right,
at the time of death, or within 42 days of death? And the addition of that, basically you've created a flag to capture, you know, maternal mortality. And, you know, many people think that the rise in, you know, in maternal mortality recently is because, you know, that flag has been created. I guess the bigger question is, yeah, and again, it's interesting that you say that the CDC data and, you know, the CDC has come under a lot of fire, of course, related to deaths and basically COVID tracking, right? And of course, I mean, the CDC has seemed to have done a pretty horrendous job of tracking stuff in COVID. And I think many people's impulse is to say that, oh, it's because of the political influence on the CDC. I'm not so sure about that, because, I mean, I've been tracking this maternal mortality signal has been interesting to me because it's hard for me. I'm not MFN, I'm not an OB-GYN, but when people say that your maternal mortality in the United States is so bad, it's one of the worst in the developing world. In the developed world, not developing world. We're not a developing country yet, though. Sometimes when you hear some of our congressional leaders speak, you know, you think maybe we are. It could be a developing country, but nonetheless, it appears to be that maternal mortality is one of those statistics that has been grossly screwed up by the CDC, and I say that because, you know, there's something called there's a program that was developed through the CDC called Review to Action. And this program specifically it's from 4 states, and it was an attempt to try to figure out how certain can we be about pregnancy related deaths. The problem is that if you use, your point is well taken about what's considered pregnancy and pregnancy later, you know, in terms of how what one does with the pregnancy, right? But that being said, right, the numbers are that maternal mortality rate, our maternal mortality rate is somewhere between 17 and 26. You described the fact that, Black patients have a maternal mortality rate of 40 per 100,000 live births. And in the UK, it's 6.6. And in Spain, it's 3.7. It's like, what the heck is going on? How are our numbers so off? But that high number per 100,000, as you're bringing up, if you assume that there are about 2.7 million annual births in the US, that comes out to some 700 maternal deaths per year. So the problem is that number is very, very small, right? So if you're off by a certain amount in that very small number, holy cannoli, your rates can drop down a significant amount, right? So just an error rate of 0.01%, right? And most of the time when we're collecting data, we know our error rates are much higher than that.
Yes.
That's going to move our maternal mortality down into line with all the other developed countries. And so the CDC panel, called Review to Action, looked at 4 states and looked at 650 deaths. And they examined these 650 deaths, right? And the first thing they looked at was, all right, we want to know, it was awesome. We want to know what exactly is causing these deaths so we can get behind, how to fix this problem. Off the bat, 97 of those deaths that were marked as, pregnancy-related death, 97 of those, there was no evidence of pregnancy. Right? So that's a false positive rate of 15%, right? Of the remaining 553 deaths in these 4 states, only 175 are thought to be pregnancy-related.
Yeah, there are homicides, suicides, overdoses, things like that. Yep.
Right, because literally, we are basing a maternal mortality statistic that has launched, I'm sure, billions of dollars of funding and has launched articles and papers about all kinds of stuff. Right?
Yeah.
It's based on a simple death marked on a death certificate within proximity to a pregnancy. If you did that for vaccines, right?
Yeah.
What would happen? The world would explode if you said any death within 40 days of a vaccine is considered a vaccine-related death. We are literally, that's what we're doing with maternal mortality. And so if only 175 are really thought to be pregnancy-related, and by the way, of those 175, we're not even getting to the question of whether or not, what percentage of those 175 that were finally decided to be pregnancy related, what percentage of those are actually preventable? Because of course, not every death is going to be unfortunately preventable. But even if you leave that at 175, right, that gives us a maternal mortality rate of 5.8 per 100,000.
Yeah, and I think
which seems realistically, living in the world, it seems to be, it's like, I don't think we're like 4 times more dangerous than Spain for some reason. Is that your general impression from do you feel like the work you're doing and your colleagues are doing, if for whatever reason we are multiple times less safe than Spain and the UK?
Yeah, that's why it does make me very, nervous and upset when I do hear those claims that we're killing women all over the place. And there's been a lot of that heaped on states. Some of it is very politically based. They'll say Texas is doing X, and currently Texas is doing some things about restriction of the right of abortion. And they'll say, look at Texas, it's so much worse than, state B that is, a blue state. And many of the times they're looking, the statistics they're not looking at the same things. So, if you're really sick in the United States, if you really have a complication or your baby is really small and really sick, you're in much better place to be here than even some of the other developed nations. It's still complicated, and it's not. We don't want to push it off and say, well, there's nothing. If you look at the maternal mortality rate per 100,000 of births of women over age 40, we're talking in the 80s to 100 per. And it's because a lot of those women have hypertensive disease. They have other things that you folks are much more familiar with. So there are also subsets that are, age and then obesity. Obesity has become a big problem. It's not the only explanation, but Anish, your critique is, I think, spot on. I was trying to be really gentle with my colleagues that I've gotten to know at CDC. I think it's the top levels, and it's the over period of time of how it's organized. There's really no incentive to just cut to the chase and say what is really important here.
Right. Do so it speaks to this notion as well. Well, I guess I'll ask because I've been commenting enough. In your experience, of your vast experience at this point, how would you attribute the most common causes of pregnancy-related deaths, and how do you get a sense of what percentage of those are preventable? You spoke with great clarity earlier on about the fact that, and we've all seen this, me, Michelle, as well, anyone who's spent any time in the healthcare system, that there's clearly are, there certainly were, no health system is averse to bias. And there's clearly are some biases that become overt. I get a little nervous when you say, okay, there's biases, and then you're going from biases to, doing things to effectively kill people. What is your general sense of, from your, real world experience about, what exactly is going on in terms of what causes pregnancy-related deaths and which ones are preventable?
Sure. Well, and I mean, I would say those numbers really are probably between 5 and 10 per 100,000. It's pretty clear out of those deaths, about half of them are preventable. And a lot of states now have really gone to maternal mortality review boards. California's got a really good program, a care collaborative that's just runs very well, and they've done a great job. So it's basically, it's infection, or it's hemorrhage, hypertensive disease, infection, then down the line of thromboembolism, and some certain things, as you mentioned, that there are times you can't prevent it. Occasionally, an amniotic fluid embolus will happen, and things are over with. Basically, you can't do anything. I've done a perimortem C-section in those instances where the mother just died right in front of us, and you just need to get the baby out. And then there's the later ones where moms do actually have cardiomyopathy, and they end up, with heart failure, and those are usually pretty predictable as well. So it is important to review all the cases, to then do, root cause analyses and say, hey, was there a failure to recognize something here? And there's a lot more focus now too. I think CDC has a Listen to Her program that they're doing. And if a mother calls in and says, I'm short of breath, and sometimes they'll just get a response from somebody at their office, someone who will say, well, you're tired and maybe you should get a little more rest. And, she's got a PE. And so we need to be really careful about the postpartum period, because stuff can happen and we really need to pay attention to that. So all of those kinds of efforts are really, really valuable. And, there should also, some systems really are messed up. There's a real interesting thing that's going on in England right now. A healthcare trust, I think Shrewsbury and somewhere else, there was a big investigation because there were a lot of maternal deaths and newborn deaths. And they found it was related to the fact that they were trying to minimize the number of cesarean sections. So they were actually doing too few. I mean, around in the developed world, we do too many, but they were doing too few. So a lot of times there's pressures being put on systems to do things. And currently, there's medical legal pressure, but there's also pressure to, address disparities. And some of those disparities are things, the social determinants of health are probably more important than some of the things done in the care model.
How many live births are you involved in on a yearly basis?
Well, currently, just from a responsibility standpoint, the 400 per year that happen at our birth center, and those are low risk mothers. I should also point out too that when we're talking, it might even get us into COVID. When we're talking about maternal deaths, so I mentioned we've had 3,300 births over the course of a decade since the birth center started. The practice did. We've had one maternal death and it was a mom at 18 weeks of pregnancy who got H1N1. And
I'm sorry, you've had one maternal death since?
Well, for 10 years out of 3,300 patients, pregnancies that we've cared for. And she was a mom who was 18 weeks pregnant and was on a trip to Florida, got H1N1, ended up in the hospital, and she was dead within 48 hours. And,
wow.
So, and to kind of, as preparing for this too, I kind of looked and said, okay, what is the maternal mortality risk of influenza in pregnancy? And you don't want to get influenza if you're pregnant, that's for sure. And so we definitely encourage vaccination. The risk, looking back through the literature, is about 2 per 100,000. And currently the CDC data for death with COVID or because of COVID in pregnancy is 4 per 100,000. I mean, so we're still talking about, real numbers, but they're not huge. And there are a lot of pregnant women now who are being terrified that they're pregnant, and because of that, they are at high risk of dying of COVID, which really isn't true. But they should be encouraged to be vaccinated.
Wait, are you saying that? And how do you know that? You're saying it's very bad to get the flu, but seemingly it's not as bad to get COVID when you're pregnant. Is that your?
Oh, no,
or it's a?
Yeah. No. I didn't mean to say that. I meant if you're pregnant and get symptomatic COVID, it can be worse. I mean, just the respiratory and cardiovascular changes of pregnancy are bad for getting a viral illness, particularly a respiratory one.
Have you had any patients through the last 2 years of the pandemic who've had symptomatic COVID, or?
Yeah, most of the ones that we have seen have had COVID that was moderately symptomatic. I'm aware of cases in Minnesota and I think we probably maybe had a handful of mothers who've died in Minnesota. Still a small number. In the US, reportedly all the way through to 28th of March, by CDC data, I think there are like 175 or 173 maternal deaths because of COVID. So,
wow.
You would think from an excess death standpoint, if COVID was killing mothers all over the place, it would have skyrocketed our maternal mortality. It's real. They can get very sick. The vast majority of the cases we've seen, it's increased my ultrasound consultative practice significantly, because every mother who tested positive for COVID or had mild symptoms, sometimes just loss of smell and taste, those moms are getting detailed anatomic scans. They're getting growth scans, because there are increases in preeclampsia, stillbirth, but they're small. They're real, but they're still small. And so it's become kind of a conundrum.
Yeah.
Like how frightened should we, anticipate these mothers can be?
I mean, would they be these risks? Would they be in keeping with any kind of viral illness one might get in pregnancy? That I suspect.
Yeah, that
right?
178 number. How does it compare to, say, the number who died in a 2-year span of the flu?
Yeah, it's a little bit more. It's probably twice as many, still from a small number. But it is. So it just presents this issue. I mean, there's stillbirth rates have increased a little bit. Early on in the pandemic, there were mothers, because of the fear of transmission and not understanding really what the case fatality rate was and all that, there were, mothers laboring alone, and, that ended. But there's still now a lot of fear about, people hear, well, the stillbirth rate has increased. So there's a lot of interventions as far as fetal monitoring, and then recommendations for induction of labor at 39 weeks. So a lot of interventions are happening that I'm not so sure are really going to be beneficial. And there's work now ongoing about placentitis. I mean, in some mothers who get COVID, there are reportedly changes in the placenta that potentially could, that's your life support system. And
in your practice, have you had any COVID related?
No. Well, we've had one mother who had COVID, pretty symptomatic. She never went to the hospital. She ended up at about, I think, 37 weeks. She started to feel decreased fetal movement. She went in, the monitor looked really bad. The baby was born, and the baby does have some degree of sort of encephalopathy. And it's hard to know exactly, was it related to the COVID? And on the flip side of that, we have all these questions about, should I get boosted in pregnancy too? And, I myself, I mean, I'm over age 65, so I've been vaccinated, mRNA twice. And so these mothers, have had vaccination. They want to know if should they be boosted. Last year, back at the end of the year, there was a mom who ended up with her booster of the Pfizer vaccine. And she told me that her second dose of Pfizer had made her deathly ill, that she had terrible abdominal pain. She ended up 8 days after her booster. She ended up with severe abdominal pain. And the long story short is she had a ruptured liver. And she ended up in the ICU. Her baby survived. She survived, fortunately, after a couple of reoperations, a lot of transfusions. Jeez. And she asked me too and said, well, could this have been related to the vaccine? And I said, well, I don't know, but we need to report it to VAERS. So I went ahead and did that. And I tried to get information from the colleagues that were the ICU doctors at the hospital across the street from us. And the response was, there's no plausible connection. We don't want to encourage vaccine hesitancy. And I just went, okay, this fits right into your mission of your podcast to say, that's crazy, to say that. So fortunately, the CDC did call back and I got them connected to just say, we need to report that, she basically had HELLP syndrome, and liver swelling is one of the things that can kill a patient with HELLP syndrome. But she was a multip. She did not have a history of hypertension. She had a family history, though, of severe preeclampsia. So I don't know. All we have to do, though, is report things and let the system work.
Right.
The difficulty is the degree of scrutiny that things have been put under in the last 2 years. Both with the vaccine and with the virus itself, is unprecedented, right? I mean, in the past, if somebody came in with, and if they had a mild, version of the flu or some other virus to trigger the complication, we would never know because we would never test. Whereas in the last 2 years, every single person was tested multiple times, and so so it's not to minimize the association. I mean, clearly there's probably a causal role that COVID in some women plays in their pregnancy for reasons that we don't know. But it's hard to know still. I mean, I think it's hard to compare that to what it used to be in the past. And same thing with the vaccine. I mean, the vaccine has been rolled out very rapidly. Yeah. And it's right. And the heightened anxiety surrounding the vaccine makes it such that it's hard to compare, hard to decide if an association with a vaccine is just hazard or real.
Right. Well, and the testing of it too, understandably, most vaccines are not initially tested. I mean, pregnancy is usually an exclusion.
Right.
And there was the concern. So, there were then women who got the vaccine and happened to be pregnant. So there was data that, overall, it seems to be safe. But the thing is too that the hesitancy started out at, I think we were back in the middle of 2021. It was probably maybe 20 or 30% of pregnant women were vaccinated. Now it's up to 70%. And there's still hesitancy. And my encouragement to my colleagues, to my midwife colleagues too, is to say, look, we recommend it. If a mother hesitates, we're not going to jump on her about that. I mean, she needs to be respected in what her choice is. If she had a lot of comorbidities, I would say you really should consider getting this. You don't want to get COVID in pregnancy. And the World Health Organization, their recommendation now remains vaccination in pregnancy is okay if the risks outweigh or the benefits outweigh the risks. And they've been under some pressure to say, oh no, you have to push it, because American College of OBGYN, the Society for Maternal Fetal Medicine, pediatric societies have strongly pushed it.
Yeah, this is all playing out in the public's eye. I mean, that's not that the public can't see it. So this, this hesitancy on the part of the critical care team to say, no, we don't want to touch that because we don't want to feed into vaccine hesitancy. And, as you said very nicely, it's like, you don't have to make some connection, but you should report it. And then if you're not reporting it, then how is the public going to feel like we are in their corner, which we need to be in their corner, right? And being in their corner means leaning into the uncertainty of what adverse events may or may not have. And yeah, it really requires reporting these things. And if enough people report it, then maybe you can make some connection down the line. But if you don't report it,
Yeah.
then no one knows anything. And this does not engender any trust in doctors or in public health if many of us do this. So
right. And on that note, any in your practice, any appreciable again, it's hard to right, it's hard to even trust our own experience, but any appreciable rise in miscarriage rates in the practice? Or?
Yeah, no, there really hasn't
Right.
been. You know, there are so many mothers, especially during the most recent, Omicron and all that. I think I know more pregnant women who have had COVID than not. I mean, it's all over the place. And most of those mothers really had mild illness. And so, a lot of them were vaccinated as well. And we just try to reassure them. Certainly it's not a cause of fetal anomalies. I think it is a wise thing to do a growth scan to just be sure baby's not growth restricted, and that's an important part of it. But there's just, pregnancy itself, the whole concept of what we're doing, we can maybe down the road have another conversation about midwifery and how to actually better care for just pregnancy in general. It's all about risks. And I've heard it way too often, because I also was involved in resident education, where a patient is told, do you want your baby to die? I mean, there's that kind of, it's almost brutality by the system saying, if you don't follow our recommendations, is it because you want your baby to die? Right. I mean, it's just it's outrageous.
It is. So that's very interesting. And I'd like to move to that topic, if it's okay here, because you mentioned at the beginning of the episode that you view pregnancy as sort of a condition of health, not a condition of not a disease condition. But it seems, I mean, if you look historically at modern medicine and scientific medicine, it's almost that from the get-go there is a bias in terms of viewing medicine as almost a quasi disease that requires from the get-go the involvement of medical professionals. Yeah. Who by definition are licensed to, and I know, I mean, I don't know the data offhand, but I read a book many years ago on the history of licensing, and that was one of the big turf battles, in the 1900s in terms of putting the midwives out of business. The doctors wanted to make sure that the midwives were out of business. Yeah. And I think that has colored the OB perspective and continues to do so to this day. And then there's one example, at least one comment I'd like to make. A few years ago, and again, that's why I think I've always been skeptical of pregnancy mortality statistics in general and how they can be manipulated. It's not unique to pregnancy, but it's certainly true there. If you look at the package insert for contraceptives. To this day, at least, well, I don't know if it's to this day, but certainly it was the case, a few years ago. There's a table, and I think they all include the same table, which is a quote from the same study, a study from 30 years ago or 40 years ago, that compares the risk of the contraceptive, right, the hormonal contraceptive, to the risk of pregnancy, to show that contraception is a benefit to the woman, as opposed to getting pregnant, which carries a higher risk. Mm-hmm. And so what's interesting is that data is so the package insert today quoted a study about maternal mortality from 30 or 40 years ago. As an aside, that study was published in the Journal of the Gumacher Institute, so the research arm of Planned Parenthood. Right. Yeah. But it showed clearly that sort of the optics here are to treat pregnancy as a disease condition and compare it to another intervention like taking a contraceptive and whatnot. And on a philosophical level, that comparison really doesn't, I mean, you can't really compare the two things. I mean,
No.
in such a way, it makes no
Sure.
sense.
Well, and there are also, obviously there are benefits of pregnancy too. I mean, a full-term pregnancy followed by breastfeeding substantially decreases the long-term risk of breast cancer. I mean, that's well documented.
Yeah, but although I mean, I'm glad you say that, because I mean, isn't that sort of taboo and unspeakable in academic circles
Very,
these
very
days?
much. Well, yeah, and the other thing that I mentioned was that, so if you look at risk factors for preterm birth, if you dig deep enough, there is very good evidence that says that previous surgical manipulation of the cervix, either for suction curettage for a miscarriage or elective termination, there is a 50% increase in subsequent preterm birth. And it's real. I mean, it's acknowledged by the experts in the field, but you will never hear it spoken about. And that to me is troubling. So as part of this committee, we've tried to at least bring the topic up and say, let's discuss this, because it's a modifiable risk factor, or at least it's a part of informed consent, for that. So anyway.
So what is the committee tasked to study? Is there any particular, or is it just broadly speaking, maternal fetal health?
Yeah, well, it's been fairly broadly speaking. We've been talking about eviction, border, border crossings, and systemic racism, and all those things are important, I think, to address. But sometimes there are a couple of other folks on the committee. We feel like, okay, can we at least maybe be a little honest here too? And I really respect the people I work with on the committee, but yeah, it just gets to that point, and all you can do is sort of try to tell the truth and see where it goes from there.
Right. So in a few minutes, can you tell us about your birthing center and your move to bring in midwives into the pregnancy experience?
Yeah, I mean, I've worked with midwives ever since my days as a National Health Service Corps person, and I've also visited midwives in Estonia, Ukraine, Spain, the UK, Sweden, and so I've seen in Germany too. I've seen how it works, and most, especially in Europe, but countries that utilize midwives as the primary maternity care provider actually do a better job. We here in the United States right now, only about 10 to 12% of births are attended by midwives. And even, I'm a member of Accad, I'm a member of the Society for Maternal Fetal Medicine. Our professional organizations, they've done workforce studies. There are not enough obstetricians to attend births, even with our decreasing fertility rate. So we're going to be understaffed. So we really need to change the way the system operates. And midwifery care with, integrated with physician care is really the way to go. So I've just been really impressed about how some of my colleagues across the street, they saw it at the hospital, they saw it as competition. And if you're also dealing with an RVU-based payment model, a lot of the physicians look at the midwives as just competition for their RVUs and their, quote, productivity. So that becomes an issue. So that's led me then to basically design a bundled maternity and newborn care payment system that's really gaining a lot of traction. Because if you're doing it as pregnancy is the ideal episode, it's time limited, even though it's complicated, it's pretty predictable how many women are going to deliver preterm, how many are going to have severe preeclampsia, how many are going to, all of those things. So it's a great episode to do that. And if you get a team working together, so the hospital, the physicians, the midwives, that's a great way to do it. The neonatologists, that's a whole separate story. Neonatology, $143 billion are being spent in the US every year on maternity and newborn care. A great deal of it is NICU care, many of it late preterm babies that really maybe don't need to be in the NICU. But if you're running a hospital, the NICU is your cash machine, basically. So everybody can talk about, we want to keep babies out of the NICU. When if you really ask them in their most honest moments, they'll say, no, we got to keep those beds full, because that's where the money comes from.
So is the relationship between your birthing center and the hospital improving over time, or?
Yeah, it has. I mean, I used to work for the hospital system. And initially, when I did this, and my midwife colleagues are great and they're very well respected and they have privileges at the hospital too, so they can follow the patients there. But the initial response to my to my work was from an OB doctor who led the system. She said, "What would it take for you to give this idea up?" I mean, I know you guys are doing private concierge medicine and whatnot, so you're totally tuned into this. And I said, well, the end of the world might make me think about stopping, but I'd probably still do it then. And I asked her, why are you asking me about what would take me to quit? She said, it's just going to make the obstetricians mad and it's too complicated. And and I said, mothers want this, that they want agency. They want, the ability to choose the kind of things they're doing. I mean, I remember July 1, 1980, starting my residency. It looked like the birth that was happening was a full alarm code in an ER. I mean, I've been attending births as a medical student too, but I thought, what in the world are we doing? I mean, so now my contention is no OBGYN resident should be turned loose on the wards until they have been taught to attend normal births, about maybe 10 of them by a midwife, so that they don't freak out and say, this is unusual. It's not. I mean, you have to recognize when things are going south. So anyway, we've had great outcomes too. So our 3,300 births, there's not a single one that I can look at and say, ooh, that shouldn't have happened. I mean, the transfers are almost always for an epidural or for things that are not urgent. Occasionally they're urgent, but 50% of American women give birth in hospitals without in-house anesthesia or OB. So anybody who would argue, you should never give birth outside a hospital, the argument should be, well, then you should never give birth outside a hospital that doesn't have 24/7 OB anesthesia and the ability to do a C-section right away.
Right.
And Sweden tried that. And they basically closed down hospitals all over this huge geographic area. And the major cause, the Swedish midwife told me, for out-of-hospital birth in Sweden is giving birth in the ambulance going to the distant perinatal center.
Very interesting. So what are the economics? I mean, briefly, just as we wrap up, the economics of giving birth in a birthing center, insurance company. I mean, are these people your patient, or I wouldn't call them patients, maybe your mothers, the mothers that come to you, are they insured, or what?
Yeah, they are. We're gaining traction. It's been a long slog. We now have a company that we're working with that connects centers of excellence to self-insured employers, which is really, they're recognizing self-insured employers understand how much they're currently spending. Mm-hmm. And if a significant number of those mothers, if they need an epidural and they want one, they shouldn't be at a birth center. So, we try to select the moms who would be best there. Right. They labor in water and they could position and all that, nitrous oxide, self-administered. However, a birth center birth can probably save 30 to 40% over what currently, and so, we can share in that savings. And so I think we're now at the point where we've reached a tipping point, and I'm very optimistic about the model of care.
And do you see a trend in that direction across the country, or just is it still pretty isolated right now too?
Well, it's kind of isolated, and I would say it's very similar to ambulatory surgery centers maybe 30 years ago. I mean, people used to think, why would you? I mean, you can't do a colonoscopy outside the hospital. It's got to be main OR. And, now we've got these focused factories basically that they do a really good job, and colonoscopies only cost $385, and so birth centers are similar, although they have to be better integrated. I mean, if from an ambulatory surgery center, you never want to be transferring your patients to the hospital. That means you poorly selected. Mm-hmm. In pregnancy, it's 15 to 20% of moms will need to go to the hospital, and that's understood, and that's part of the deal.
Okay.
Yeah.
Terrific. Anish, any last thoughts or questions? Yeah.
So there's an editorial in Jack 2020 on the potential for pregnancy heart teams to reduce maternal mortality. But forget anesthesia.
Yeah.
We need
you need cardiologists, right?
We need cardiologists. We need a cardiologist manning all pregnancies.
That's right. That'll be a new subspecialty.
What are your thoughts seriously about cardiac obstetric teams and the need for that?
Well, I mean, one of the few, but in my career, one of the pregnancy deaths was a woman from Vietnam who had big VSD, and she ended up with pulmonary hypertension, and she was counseled early in her pregnancy. And so, in my world, if she had chosen to end her pregnancy, I would believe that would be a legitimate thing. And she was told this could be lethal. I mean, your chances of dying here are maybe 1 in 5. And she continued her pregnancy. She got to 28 weeks, got severe preeclampsia, got delivered, and afterward, her cardiac status deteriorated so much she died. And her husband told me she wanted to do this. She knew exactly what she was doing. I miss her. We're grateful for our daughter. And it's that kind of thing. So it's really great to have colleagues, renal specialists, cardiologists, neuro people, when someone blows a, circle of Willis thing when they're pregnant, it's great to have specialty colleagues who can then help you just take care of those patients.
Yeah. In this particular patient that you're describing, this was known going in. I'm sure cardiology was involved.
Absolutely.
When the patient got very ill, so would this be classified a preventable death?
Well, yeah, I guess you could say that if she had chosen to end her pregnancy, but you never know. I mean, if that might on its own right have helped or not. But I would say that was almost like a predictable one. It was
right. But cardiology, even though there was a cardiology team that was there, they weren't able to do anything. And
she was in the cardiac ICU. Yep. She just they couldn't open things up. Her heart had worked too hard with that, VSD.
Do you find, since we're cardiologists, I have to ask, do you find that, well, I mean, it's a rare event, but the things that you mentioned in terms of preventable things are hemorrhage and infection, right?
And then hypertensive, like so preeclampsia, eclampsia, and then subsequent cardiovascular disease.
I see.
Yeah.
Yeah, I'm struggling with like what exactly we can do with these obstetric teams, other than like maybe diagnosing a cardiomyopathy up front, so you're able to know. But how exactly we help?
I've had a few moms where they come in and they say, "Oh yeah, when I was down in Louisiana, and after my last pregnancy, I couldn't eat very well, and they had me on diuretics."
Yeah.
And, oh no,
right. That's the tell, being on diuretics for sure. What do you make? We kind of we never actually dove into. What do you make about the significant difference related to race when it comes to maternal mortality?
Well, I think there is a component of the way that Black women in particular are treated. Just one thing to leave you with, there's the public health program here at the University of Minnesota has a specific anti-racism chair, and they released a study saying that increased policing is associated with increased preterm birth. And it made my head explode. I mean, when you read through it, you just go, that's just association. And I feel bad because there's a lot of good work that comes out of some of those programs. But so I'm not trying to minimize the specific, the importance of it, but we have to also then look at it in just sort of a pro-human thing, saying, look, we need to have better care. People need to be really treated with respect. Black women that get care at our birth center, and it's about 15%, they do experience a different model of care. They feel empowered. And so we're doing what we can. And I think there's a great study that came out of the Affordable Care Act called the Strong Start Study that actually showed that racial disparities and preterm birth and all of that were improved by midwife-led care with an intention to deliver at birth centers. So we've been hammering away at Medicaid agencies in states to say, hey, there are better ways of doing this. And it's bipartisan. And I would end with the people I work with. We don't all share the same beliefs about everything. We all agree that pregnancy is not a disease curable only by C-section. I'm hoping that many of them will also understand that even pregnancy, when it's a little earlier and unexpected, is also not a disease. I mean, it's complicated. Things are complicated, but I appreciate you guys taking the time to.
Thank you.
Thank you very much, Steve. Are you on you have a blog or on social media or any place people can follow what you?
Not too much. Well, for a while, in the past, I tried a Twitter thing called Birth Bundler, so I might try to go back on that and try to see if I can get myself in trouble there.
Right. Very good. Thank you very much.
Thank you so much.
Have a good weekend.